incredible session, impeccable timing, Google. Thank you, dear speakers online. I think I already have Maria Dutarte on the floor, Zoom floor. If we can bring Maria Dutarte online, as Pedro unfortunately cannot join us, he had an urgent engagement with the Ministry of Education in his hospital, so he cannot join. I will be your moderator. So I'm calling in to the floor, besides Maria already in Zoom, Alexandra Steges from Biobank Charité. Please, a round of applause to Alexandra for joining us. These days, the persons who attend physically deserve a round of applause, right? Thank you so much. And also, I'm calling to the floor, but not so distant from us, Ines Sousa, Head of Intelligent Systems at Fraunhofer, Portugal. Please take a seat. Also from joining us. And we have Maria Dutarte online. Maria, a round of applause for Maria too, even though she's online. Are you listening to the applause?
Thank you so much. I can hear you, but not the audience.
You can hear me, but not the audience. But I can assure you, it was a warm round of applause for you.
Thank you.
I'll try to connect the microphone to the audience to listen to the applause in the end. So I think it's my privilege to be the moderator of this session. I hope to be up to the stage. Sorry? Oh, Chantal. Oh, I'm so sorry. Thank you, Chantal, to find the Chantal Steegers. Another round of applause. So sorry. As I told you, I'm just replacing moderator, so I hope you bear with my... Okay, so I think there's an order already established here that's going to be followed by Alexander speaking first, right? I think it's that what we have here in the program, so let's stick with it, and then hopefully we have some time for Q&A before we wrap up the session.
Yes, thank you. Thank you very much for the invitation. My name is Alexandra Stege. I'm a biologist by profession, and since 2006, I'm into the field of biobanking. And so now we have a little bit of a skip because I'm not talking about data directly. So how can I handle this? Let's have a look. Yes. So if we are thinking about real-world data, the most people would not think of biosamples and biobank first, because if you think of samples, you think they are in freezers or maybe in archives, and before you can use them or do some research on them, you have to do some analysis, or genomics or proteomics. But to be honest, if you have a look at samples, they are still a snapshot of the status of the patient at this time and can be very helpful to understand the disease, especially when there is coming up new techniques or biomarkers to characterize the disease and the patients more deeply. So, okay. So when it comes up to biobanking, then when I come to the field 2006, and I thought, okay, it's easy, I have to standardize the sample collection. But during my time, I find out there is more I have to stick to. And first, if you want to reuse data and also samples, you have to follow or align to the FAIR principles. So these samples and data have to be findable, accessible, interoperable, and reusable. I will not elaborate these principles because I think you are very familiar to that, but I will tell you something about how we got how we address the findability of samples. So there is a little bit of a mess up. Okay, I will talk in the context of healthcare integrated biobanking. So as we know, there are different sources of data and samples as well, but I will tell you something in the context of healthcare integrated biobanking. So as I said, we have to align to the FAIR principles. But that seems in the first time it's easy, but we are not working in a lab totally alone. We as a biobank have a lot of stakeholders, which needs and expectations we have to address. So there are some ethical, and also ethical points, and we have to train and educate the people who are working by collecting the samples. We have to annotate them. That's very important if you want to use them. We have to stick to digitalization and also to sustainability. And then the next thing is, because there is a need to share samples, because in an institution, we often have not enough samples to do real deep analysis and really statistical interesting results. So we have to stick to also national and European perspective. And I want to give you or introduce two institutions which are very helpful for us. That's first the German Biobank node. That's an umbrella organization for the university hospital biobanks. And they are focusing on IT, sustainability, and further subjects. And also the BBMI ERIC. That's a pan-European platform for the use and the collaboration in the context of data and samples. So findability of samples is very important because we have a lot of freezers with a lot of samples and we want to share them and use them. And in Germany, around about 10 years ago, the Medical Information Initiative started to address this problem and started to set up a framework. So they addressed the topic on generating first the framework, the governance for use and reuse of samples. They set up a broad consent. So that's in Germany very, that was a problem because the most collections of samples are project specific and the broad consent was an issue because this has to be approved by all of the federal ethical committees. And this is now in place and rolled out to the university hospitals in Germany. And that brings us to the point that we are able to make them findable. So last year, there has been launched a platform that's called Forschungsdatenportal für Gesundheit, so research data portal for health. And there you can search for samples and data which have been collected in the context of the broad consent. And there is an use and access in place. And what we have also do from the biobanking side is that we also have that's called the sample locator. There you can also search for special samples which have been collected in the environment of the university hospitals. And if we are looking to BBMI, there are two options. There are the possibility to find not only biobanks, but also some collections which maybe have been collected during a clinical trial. And you also can request samples. There is some kind of negotiator where you can put in your requests and then you hopefully will get an answer from a biobank European-wide. So this is the pipeline. I will not go into detail because it's very complex and I'm not an expert in BBMI, but I think that's a great opportunity European-wide to elaborate this use and of samples and data. So, but it's great to have everything in place, especially the frameworks, the ethical and legal frameworks, but we are nothing without the donators. So we also addressed different stakeholders in the context of biobanking. And here I want to show you some examples how we do this for the donors. So we generated different flyers. We have in place such a short film who explains what the biobanking is doing and in which framework it's doing. And we have some activities during the long night of science where we show what we are doing and the kids are able to do some biobanking work. So they are aliquoting some liquids, and that's always a pleasure to get in direct contact to the people. So, and I want to end by this. Thank you very much for your attention, and
I'm happy. Okay.
Chantal is going to be the second to speak, and it was lovely to see the human side of the biobank with the nice pictures in the end. Chantal,
much.
yes,
Yes, the
maybe
slides
you would
are-
like to introduce yourself a little bit first and then speak.
Sure, sure. So thank you very much for the invitation. I'm Chantal Steegers. I am Manager Public Policy Affairs and Communication at RWE. You already heard something about RWE just now by my colleague, Niels Bolding. He's the techie within our organization, and I'm not the techie. I'm the public policy and communication manager. Actually, I see the slides here, but I don't see them there. Okay, thank you very much. So as Niels already told, our mission, better health for citizens and patients. Well, who does not want that, right? But we want to achieve this by reusing the health and the life science data that are already out there, because there are so many data sources with real world data that we really need to utilize to make our healthcare better. And how can we do this? We think by making an integrated data infrastructure on a national level, ideally, of course, on a European scale, but this task is already quite massive. So we're dealing now in the Netherlands to get this done. And why do we want to do that? To enable data-driven research, policy, and innovation so that the knowledge and the innovation that comes from that can make the healthcare better again. And as Niels said, the problem is fragmentation. We have so many different point solutions when it comes to data reuse. And it's not only a technical problem and a challenge, which it is, it's above all also an organizational, social, and cultural problem. And that's something that we have to deal with the whole ecosystem to get to good agreements and a national set of agreements. So the result of fragmentation, as we already heard just now, when it comes to the samples, the biobanking samples, is actually the same as well for when it comes to the real world data. Data are hard to find. They're scattered everywhere. And where do you start when you're a researcher and you want certain data from several data sources? And when you find those data, they often they're not accessible. They're inaccessible due to different procedures, different access procedures. Some say yes, some say no, they really want a different right of say of the patient or the citizens that are involved. So it's quite difficult. And then they can't be linked on a personal level again between the sources, because in the Netherlands, we're not allowed to use the personal identity number when it comes to research. Of course, in the primary healthcare sector, it is allowed to use the personal identity number, but not when it comes to research for secondary use. So we need to tackle that problem on a national scale. And then when you have all these data from different sources, it's often hard because you can't combine them because they have different information models, different standards, and the computer can't really read them. So it's all handwork of this researcher, which costs a lot of time, a lot of effort, and it costs a lot of money that is not spent for the healthcare for the citizens and the patients. And then when you have your beautiful research data set, you've published your article, then actually we want that research data set to be reusable again as well. But then again, where do you find those? Unless you, of course, read the articles, which researchers do. But so the result of national collaboration, what we're trying to do as RWE is to make the data fair, findable, accessible, interoperable, and reusable. And we have, in order to do that, we have to work together with all stakeholders in the ecosystem towards one goal. So we need to work with the government. We need to work with the patient representatives and the patient organizations, with industry as well, with funders of research, with the data holders, the GPs, the hospitals, their umbrella organizations, to actually get to a national set of agreements. And that's tough. But we have to do it. And we have to work on this national set of agreements on how we actually want to build the technical infrastructure, but also how we want to use it. But how do we do this? How do we align all stakeholders and not focus on one specific project or on one specific point solution? Because we need an integral approach, because everything is, well, not everything's connected, but if you make a technical choice, it affects your access policies. If you make a choice on the access policy, it has ethical considerations that you have to discuss, and you need the trust of the patients and the citizens. So we have an integral approach in the Netherlands to realize this national infrastructure and to get to a national set of agreements. And we call it, it's an awful name, the obstacle removal approach. And why does it have this awful name? Because we wrote it down, what are the most important obstacles to tackle and how are we going to solve them? And we did this together with the Ministry of Health, the Ministry of Education and Science, and the Ministry of Economic Affairs. And then you come up with this beautiful name, obstacle removal trajectory. But now it's being used in the Netherlands. It's actually also being used by the government in their policies, in their documents, in their letters to the politicians. So we're going to stick to this name. And these obstacles, we clustered them in 3 clusters, but we always try everything we do, every activity, if it's technical or it's more stakeholder approach or ethical, we always try to see which obstacle are we trying to solve here. And now to have a little bit of a deep dive, I already said we work closely with the Dutch government in this. So we're not as a separate organization or project, we're really in this together. And we think that's absolutely necessary. To deep dive into one specific obstacle in cluster 1, for instance, patients and citizens are not well informed about the importance of reuse of healthcare data. And they have to be informed because they have to make a choice, either an opt-out for certain reuse purposes or an opt-in for certain reuse purposes, or they have to be informed about certain purposes where you have nothing to say about at all. But it's very difficult to get Jeffrey on the street, for instance, as an example, to get him to understand what is healthcare data, what is reuse, for which type of research is it being used, what is my right of say. It's difficult to inform them on a national scale. So what we did with the Ministry of Health and with patient organizations, we made a platform, Data Improves Lives, as a platform where general information about what are healthcare, why are they being reused, how is your privacy safeguarded, and what is your right of say. It's very basic, but at least it helps GPs, hospitals, other data holders to guide their clients and patients or the general citizens to this platform so they can get this information. There's some movies on there, there are animations, and of course some text, but it's all on a very general information, so everybody can understand it. In Dutch, we call it B1. But also we need to create this common ground and understanding with patient and citizens organizations. So we work closely with them. We organize societal dialogues to really understand their opinions, their views, their worries, but also we see chances to improve. So we can take that with us when we are really building that technical infrastructure. And we have in our governance a societal advisory board with patient and citizen representatives that give us advice on how to go through with the infrastructure. And in cluster 2, to deep dive a bit on that, Niels already stated we're working on a national registry for dynamic patient and citizen rights of say. So now if you go to a GP or a hospital or another healthcare provider, you either get no information at all about the reuse of the data that are registered about you. Some do give you some information, but it's tailored specifically for that healthcare provider. And there's no national way of communicating and actually guiding them towards one place where they can register their opt-out or their opt-in. So we're working together with an organization to get a national registry for the primary and the secondary care to register your choice. And cluster 3, which is the technology put in practice, was already covered just now by Niels. So I hope this gives an overview on how important and necessary it is to align and to work together with the whole ecosystem, especially citizen patients, to create a national data infrastructure and to prevent fragmentation and to enable data-driven health and life science for better care. And there's a saying in the Netherlands, If you want to go fast, go alone. If you want to go further, go together. But sometimes it will go a bit slower.
Thank you very much, Chantal, for this impressive duo presentation in this. I think everybody now gets an understanding of the great work you're doing in the Netherlands. So next in line, Ines from Fraunhofer, Portugal. She is going to give us a project of incredible work they're doing at Fraunhofer, powerhouse in research and development. The floor is all yours, Ines.
Okay, hello, good afternoon, everyone. So starting by presenting myself a little bit. So I'm Ines Sousa. I lead a group called Intelligent Systems within Fraunhofer, Portugal. Fraunhofer is a non-for-profit organization devoted to applied research. So we work together with different stakeholders in order to translate innovations and scientific knowledge to practical applications and to put this innovation at the service of the end users and, of course, our partners. We have been working with one of our main areas of application is digital health. So we have been working in different projects with real-world health data, partnering with hospitals and healthcare providers to create machine learning models that can learn from the data in the hospitals and systematize this knowledge and apply it to generate predictions or to generate automatization of some tasks. I can give you an example. So we heard about cardiothoracic surgery. So one of the projects we had was precisely with a hospital here in Portugal, with the data they have been collecting for 11 years on a cardiothoracic surgery department, structured according with the EACTS questionnaires, as we heard. And so we were, of course, working with this data and creating a model to predict which patients are at higher risk of having complications until 1 year after the surgery. And of course, then the idea would be to follow up these patients more closely or resorting to monitoring technology or other kind of approaches. It was really interesting to see that with the analysis we made and the models we created and the feedback we were and the interactions with the clinical team, to see that they were also having insights in how they should maybe do some small changes in their processes or in the way they were providing care, and this was really interesting. Actually, to do this, we had, of course, to go through all the approvals, to go through having access to data, and this was data that was more or less structured, and it was just an example. And what I can tell you is that we are a team of 30 data scientists and machine learning engineers, and we really want to help in applying this data science and machine learning knowledge to real problems, but it's very difficult to have access to clinical real-world data, and it's sometimes frustrating to have this limitation. And of course, there are steps that need to be followed, and the respect for the privacy of the data is, of course, very important. But we thought there should be a way of overcoming these limitations, and this was our big motivation to propose this project I'm talking a little bit now, which is called AI SimFormed. And so the mouse is not working. It is. Sorry. Okay, so the arrow is not. The arrow is not moving. There. Okay. No, I had a video, but okay. I had a small video to explain the project, but you can go to YouTube of the project and you can watch the video. So basically, what we are trying to do in this project is a a little bit the same concept we heard about health RA initiative, but of course this is a research project, and we want also to implement some more advanced techniques to guarantee data privacy and to have a platform that can have the input of clinical data and research data and health data in general organized and kept private within this platform, and then machine learning scientists, companies developing new machine learning based products for healthcare can access this data and implement their solutions. Of course, the fact that the platform has the potential to combine data from different locations, different countries, different sources, can ensure that we have a more robust representativeness of the clinical conditions and of the patient data. Of course, to ensure privacy and to advance the technology further, we are developing not only these federated learning concepts and multi-party computation and privacy and cybersecurity by design, but also synthetic data generation. And I will bring just a small example of what I mean by synthetic data generation and how can we also measure the properties of synthetic data to ensure that we are, in fact, in one hand, replicating the real knowledge and the real properties of the real data, and on the other hand, protecting the privacy of the real data. So here we have synthetic images of the retina, and you can see that in an hypothetical case, we have real images distribution in blue, and then we have the synthetic images distributed in red, and we can understand in one hand if the data is matching this distribution, and in this case we have samples with high fidelity because they are overlapping, or if they are outside the distribution of the real images, then they are low fidelity. On the other side of the image, we have the privacy metrics, and in this sense, we will see how close the synthetic samples are of the real samples. And if they are too close together, then this is a privacy breach. We cannot consider this data point for the synthetic data set, as we are not keeping the privacy of the data set. So we are also working together with clinicians, with healthcare providers in order to make, and with data scientists, of course, in order to make this information understandable and to generate reports on the quality not only of the real data, but also of the synthetic data. And we are working on a more transversal question for clinicians, which is how to evaluate synthetic data on a clinical point of view or perspective. We have these metrics, but the metrics will not cover everything. What is missing? We started this conversation. So we opened a community of practice, which is a way of bringing to the project everyone interested in this topic of sharing health data, of synthetic data, of privacy, of healthcare data. And anyone is invited to join, so please do. We will be having workshops, knowledge sharing sessions, but also focus groups and discussions on these open topics. What should we do with synthetic data? What should we not do? How to evaluate it, and much more. And yeah, so now, if you want to know more about the project or join our community of practice, now it's a good time for a picture of our QR code.
It was an interesting presentation, and it's for me also a surprise of this community that everybody can now join. And I'm glad that this forum is helping to expand the great work you're doing. Thank you so much. Last but not least, Maria Dutarte, she's on Zoom now. and we expect much the patient perspective to be heard in this forum, right? Because as we already witnessed so far, it's an important perspective to get everything aligned. Maria, are you with us now?
Hello, I hope you can hear me well.
The floor is, the virtual floor is all yours.
Okay, great. And you can see my slides as well?
Yes, we can.
Okay. I'm very happy to be with you today, and unfortunately couldn't be there in person, but I'm calling from Brussels, where I'm located. So my name is Maria Dutarte, and I'm the director of the European Patients Academy on Therapeutic Innovation, EUPATI for short. And I'm just going to say a few words about EUPATI as an organization first, and then reflect on how real-world data is changing patient involvement and what the implications for patient engagement are.
Maria, before you proceed, maybe just to remind you, we are not seeing your full screen. Is that all right?
Okay. Let me, thank you for that note. Let me try this format.
Now it's full screen, yes, thank you. But we are seeing second slide.
Yes, okay. This was my first slide, just our name of our organization. So a few words about EUPATI. We are an IMI project initially. So a European Commission launched a project called EUPATI in 2012. And we are now a non-profit organization established in the Netherlands formally. And we are a patient-led multi-stakeholder educational initiative. And so we are not a patient organization in the traditional sense, but we are a training academy, an educational initiative, and want to build the capacity of patients and patient representatives to be partnering in research. So really, what we do is we provide education and resources that enable patients and research to collaborate. So for the patient education side, we have an online toolbox that's today reaching close to 8 million users worldwide in 14 languages, which contains materials about different stages of medicine's research and development. And we also have an online and in-person patient expert training program. So it's a blended one-year program for patients to be studying with us about medicines research and development. And this program is also provided through the so-called EUPATI Open Classroom. So it's an online learning platform. And for researchers in academia and industry, we have shorter trainings, workshops, trainings about patient involvement, what it means to involve patients in different ways, meaningfully in the research processes. So we address all stakeholders with our research, with our materials and education. And the topics that we cover are really wide. We start from the, let's say, the non-clinical space. We have a lot of materials on clinical research, regulatory, health technology assessment, but now also the medical devices and digital health, which is, of course, the topic for today. And this may be something you have seen before. It is our patient involvement roadmap, which forms the curriculum of all of our trainings. And this sort of maps out the traditional medicines R&D life cycle, and also the different endpoints where patients can be involved. And so when we plan our trainings and materials, we focus on these different endpoints. We sort of teach the content of what's happening in each of these stages, but also look at the role of patients in these processes. And now we have added now as I mentioned, new areas like medical devices and digital health. And just a few words about this latest addition, an online training module on digital health, which was produced through a EU-funded project in 2020 and 2021. We had a multi-stakeholder consortium that built an online course on the basic definitions on around digital health, use of it in diagnosis, treatment, and prevention, and also the development processes and the governance. And we have also a chapter there on real-world data and real-world evidence, which we are currently expanding. And I will come to the point on education and capacity building a bit later in my presentation. And what we are seeing actually is that this particular online module is currently being accessed by close to 10,000 users already on the online platform, as all of these resources are free. This is the main idea for EUPATI since we launched, is that this should be free access and available to all patients, and not only in Europe, but all around the world now. So when I was reflecting on the topic for my presentation today, we of course see the promise of these new technologies and digital health for improving prevention, diagnosis, treatment, and monitoring and management of health-related issues, which is really essential for patients. And we also see that part of this promise is to improving access to care and the quality of care. And real-world data evidently is one of the key elements in this picture. So how is real-world data then reshaping public and patient engagement? And we can see 4 different roles that patients play in real-world data, in relation to real-world data. We can see patients as generators of data, obviously through the active use of digital tools. This includes self-monitoring and tracking and apps, wearables, home monitoring devices. And in this role, there is also this link to empowerment. So patients are empowered to monitor their health in real time and manage their conditions more effectively. And we see that patients can then make more informed choices based on this data and the monitoring. So this is seen as something very positive. Secondly, patients can be seen as contributors to the data collection, and we see many examples today of patients voluntarily contributing their health data for research purposes. We heard already about registries and studies in this session. Here we have the use of patient-reported outcomes also very actively. So patients can see the value of contributing to large-scale studies and these registries in order to advance medical knowledge and public health, and also see some benefits for themselves and their patient communities. And thirdly, which actually is the point that's really close to my heart and strongly driven by organizations such as EUPATI, is the role of patients as co-designers of research and data collection. And I see that this particular role is enhanced through educational efforts, where patients' readiness is enhanced to communicate their experience living with a condition to the researchers. And this kind of informed voice can play a key role in the data validation and feedback. So we see that patients can contribute, provide insights about whether the data is relevant from patient perspective, and also to ensure that the patient-relevant aspects are not interpreted in a biased way. So we see that patients can be really meaningfully and actively involved in the different stages of planning and conducting this type of research. And last but not least, we see many community-driven initiatives today. It's has many. This type of research has many names. I called it here the community-based data collection. We see that different patient communities can promote the collection and use of real-world data and real-world evidence that reflects also diverse patient populations. And this is something that many patient organizations today see as one of their key priorities. So before going to talk more about the educational aspects here, just to summarize that overall, I see that patients can be actively involved, but also driving every stage of these types of studies, working alongside with the other stakeholders, researchers, healthcare professionals, and policymakers. And we see that these patient insights are crucial in defining, for example, the entire research framework, selecting what is suitable data, what are the suitable data collection tools, and what are the most meaningful outcomes, and advocating for broader participation of the community. So there can only be benefits for all of us in involving patients. And there has been, we have conducted surveys, and especially, for example, European Patients Forum in Europe, a large umbrella organization, has worked on this topic since many years already and has conducted surveys around what really matters to patients in this area. And you can see the little post-it notes there in white that are really the key issues that keep coming up in these kind of surveys. And we've heard this already. It's transparency, clear information, but also the question of language often comes up. What is the type of language we use when we explain these issues to patients? Is it accessible? Is it in lay language? And is it in their own language? This also relates to the informed consent that needs to be accessible and understandable. And the other key topic that often comes up is concerns around data privacy and security. The question, who controls my data, who uses it, where is it going, where is it stored, and who benefits from it. So this is very important to keep in mind that the patient perspective is often concerned by these issues. So last but not least, I wanted to highlight the importance of patient education and this type of awareness building, where especially we are very active in this area, and we see that providing education and skilling up and learning about these new technologies also increases the trust between the different stakeholders and encourages patients to be involved actively. And this leads to more opportunities for this kind of co-design and meaningful patient involvement, and the patients' involvement actively in, for example, feedback and data validation. So these are all interlinked issues, but equally important.
Okay, you have spent 8 minutes already. Oh,
thank you. That closes my presentation.
fantastic.
Thank you so much.
In the right timing, Maria. Thank you so much for this presentation online. It was almost as you were here. I think, I'm not sure Sophia is here, but maybe in the end we need to have a massager to massage the necks of our guest speakers here. They had to turn about that, so sorry about this. But I think we have now time, and thank you so much for being time for broadening a little bit the discussion to the audience here. I'm sure there will be some questions, and while the audience prepare the question, and while also the Zoom participants, if you want to manifest your interest to do a question, please put in the chat your name, because I have here a list of who is in the room. And I see there's so many assistants and also some patient associations in the room. Before you prepare warm up for questions, I would like to propose something, is that for each one of you here, panelists, starting from the order of sitting order, and then perhaps last Maria, to in a word or two, what were your takeaways from what you've just heard? Because there's a useful combination of perspectives in this roundtable. So what will be the takeaway from these perspectives that were shared here so far? So quick snap from each of you, and then the audience prepare for final questions if we have time.
Well, I think a quick takeaway. Okay. I think I really liked a lot of words of Maria, but one word on our slide, which was co-designing. And for her, it was specifically with patients. And I think also from what I heard of you, Alexandra, and from you, Ines, that we also have to co-design with all these stakeholders involved, because it's such a complex subject and issues we're tackling here with real-world data and to get to real-world evidence, whether it's a clinical trial, randomized clinical trial study, where it's retrospective use of the data that we're more focused on in Health.RWE, or it's an observational cohort study with biobank samples, for instance, we really need to co-design with the whole ecosystem. That's my takeaway.
My takeaway is first a very positive thing, that all of us are very interested into the engaging of the patients, and that they are really that we have to focus on them, and then that we have to bring them on board, because they can be very helpful for us to support, especially when it comes to sharing of data and samples. And something maybe negative, we still have the issue that the sharing of samples and data hasn't been solved so far. But hopefully maybe in 10 years, when we have the European health data space, we have not anymore these problems for data, and maybe also for samples.
Thank you. So for me, it was inspiring to see that so many people concerned about making the data fair and standardized finally. So this is starting to be a reality, and also, of course, communicating to the patients and making them understand the value that their data about their disease may have for future improvements in how we care for this type of patients in the future.
And Maria, your takeaway?
Thank you. I'm encouraged by the pace of the development in this area. We've, of course, been talking about this topic for years already, but we are now seeing that this is becoming a reality. And this can only be positive for all stakeholders, including patients.
Thank you. Thank you so much, dear panelists. Now the audience is having the voice. Please identify yourself before you speak, so we know which stakeholders' perspectives we are listening from. Thank you.
Good afternoon. My name is Rudyard Hill. I'm the Chief Clinical Information Officer for Wales. One of the issues we have in the UK is the patient's right to be forgotten within the data set. How are you addressing that within your individual countries?
Thank you. And I will answer.
Let me understand correctly. You mean totally the right to be forgotten, or the right to be opt-outed for reuse? Removed. That will be more focused in the primary healthcare sector as well. I'm not a lawyer, but I know that patients in the Netherlands can go to their GP or hospital and ask to see what is registered about them and to have certain things removed, but it's not standard practice.
So at the Charité, we have there a special institution where the patient can contact and say they want to have the complete removal of every data which is into the system and to the hospital system. And then there are processes to remove all the available information and samples as well.
Okay, so from I cannot really speak for the country, but for machine learning purposes, we don't really need to trace back identities. So we are assuming that the data is de-identified and anonymized as much as possible. So we are trying to work with anonymized data to build the models. I know this is a challenge, but because it's very difficult when you have a model already trained to remove a specific sample and then retrain the model, it's a very complex process. So,
Thank you, Maria.
I wouldn't know. I don't work at this with this question, but our challenge would be then to be informing patients about their right to be forgotten.
Thank you. Okay. Questions here? Thank you, audience, for asking questions. It's great to have your interaction.
Yeah, thank you. I just want to join the discussion, yes, because is it really sounds like you should remove data, or it sounds like forget data? That means if data de-identified or anonymized, they should not be removed at all, because you could not identify back the patient. I don't know. I'm not expert, but that's recently we discussed with the German guys. They said maybe just they identify and that's all. So just remove identities.
You know, I talk about the information which are in the hospital information system and also the samples which are in the archive and at the biobank. So they can be identified because we have a third trust party, and they will do the re-identification for us. And then they say, it's okay, you have to delete the complete information and the samples, but we are not talking about data and samples which have already been used in projects, because they are pseudonymized, and then it will be a problem to do that. And in the informed consent, this is a passus where they said everything which has gone to a project can't be deleted anymore because of that.
Yeah, I think we really need to really deep dive in to understand really what we're talking about here. Is it being removed from the electronic client or patient registry in the primary healthcare setting for your own treatment? Or do you mean being removed from a study where certain summarized or anonymized data are already being used? That's not what I meant. I meant the first part. So I'm not sure what your question was about, but I think the second gentleman was referring to the research part. Okay, okay.
You can anonymize it, so you can talk about fingerprint of like patient. You can still like instead of removing data, you can add extra data which will anonymize this patient and still keep the record without identity. Because technically it's almost impossible to remove from all backups and all the stuff. So.
Yeah, that's a problem because when I'm looking at our system, we have a professional biobank information system. So when we are deleting everything, we have still the information in the audit trail. And that's a little bit complicated to do this. And we are not allowed to do this because we need this audit trail. So yes, you're right. In a way, it's not possible anymore because of the technical framework or the technical infrastructure to delete the data completely, but the access is minimized in this case.
Yeah, Frederick Nyberg, University of Gothenburg. I have a question that sort of intersects with the previous session also. Niels mentioned the fact about minimizing data delivered. And I guess that is linked to the GDPR provision of data minimization for the need you have of the data. On the other hand, we are increasingly moving into applications and areas where we talk about big data, and we need the big data, and we want to do AI applications and as much data as possible. And even as a researcher, I always find that, you know, I need to do deep dives into the data, even if the final model perhaps includes a limited set of variables. I need to deep dive here and there into the variables. So my question to you is really, where do you see the balance of this dichotomy, and how do we manage that balance, both from a legal perspective and specific for this session, also the second part of the question, from from a patient perception view, how would they view this problem?
Thank you.
Well, as we see it, is that the most relevant data that are actually really necessary for the specific research question should be used for that research question. So I don't know, Niels was talking about more the technical minimalization part. But as we see it in the future, with the Health Data Access Body, if there's a request, you need to provide your research proposal in a certain way, and you really have to think about beforehand what data do you need specifically for your research question, and then of course the central review committee should really check if that's really necessary to answer the research question that you have. And I think if we make that clear also towards the citizens and the patients about whom the data are, they will, and they have the trust that the safeguards are put in place and are working correctly, that that you can explain it to them as well.
Fantastic. We have also a question from online. If I may go from online and then inside, so we make this more hybrid, if you may. A question here from Alexandra Guedes da Silva, is the president of SPAM, MS Society Portugal. Trust and motivation are fundamental to patient involvement in any data operation. How can we provide full trust? How can we engage and motivate the patients to provide the data, namely the continuous introduction of EPROMs? EPROMs. I'm sorry, PROMs.
You mean PROMs?
PROMs.
PROMs.
And maybe you can explain also PROMs. Maybe the audience does not know.
Maybe Maria?
Yes, would you like me to start here? I mentioned trust in my presentation, as it is a theme that comes up continuously in the conversations with patients. And I think education and training, awareness building is one part of trust creation, but also we see that peer education has a role here, and also mentoring among patient communities. So when we see that these questions become sort of there's ownership by the community themselves, the trust increases. And we've seen that also implementing best practices in collaboration in this kind of multi-stakeholder collaborations. I was happy to see that example from the Netherlands, for example, in this session, working together and really getting to know each other's point of views is a key there. And I think I also go back to the question of language, because if we don't seem to be able to speak the same language, we will not build trust either. So how to both ways come into the middle in order to understand each other and each other's point of views. And maybe just go back to the other question from the audience. I think if your questions, first of all, the research questions have been clarified and consulted with patients that they are relevant, then also looking at the quantity of your data or the large data pool is going to be easier when you have a good research question that is relevant for patients. And PROMs are, of course, the patient-reported outcome measures, the really important tool that can be used as well.
Yeah, thank you very much. So my name is Osama. I think one of the biggest bottlenecks that we have in the whole research process is the patient consent. And what we see today that patient consents today is like almost patient consent 20 years ago. But I think that innovation can help us a lot in building the new generation of patient consent, which has multi-preferences, which has maybe AI assistant that can help patient to make decisions, summarize the whole thing, even building the trust model, which represent the reputation of the researchers, the topic itself, which is new or old. It could be like kind of computing everything and summarize it to the patient, so they can make decision not only for the research in hand, but also for similar researches around the same topic. So how do you see this happening? Yeah.
Well, I fully agree. And what I tried to explain in the presentation in the Netherlands, that's exactly what we try to work on, a national registry to have an informed choice as a citizen, whether you're a patient already or not, or as a patient where you're already in the healthcare sector. And it needs very good general lay information on what is exactly the choice you can make and for what, which choices are there to make. So it can sometimes be a consent for specific purposes, sometimes can be opt-out for other secondary use purposes, but it must also be clear that maybe for some like information goes to a Central Bureau of Statistics, that you cannot opt out for that at all. And I think if you have that put in a central place, and of course it has to be incorporated in the whole infrastructure, as Niels already showed in his blueprint of the infrastructure, then at least that's one place, a central place where patient citizen can go and find information, what was the choice they registered for several purposes. And also for the clinicians, it's easier so that they don't have the individual burden of the administration for every patient to do so.
Okay, I'm sorry you cannot take more questions, but we can have some final comments by the panel in order to conclude.
Yeah, but I thought we had the conclusion as a first question, but I think we are on a good way. We are aware that the patient engagement is really needed to come forward and to go forward. For me, the perspective to use broad consent is absolutely an achievement, and hopefully that will work. And we will see what will be in the next 2 years.
Okay. As a final remark, I can say that I believe the European Health Data Regulation sets a framework and a perspective that has a lot of consensus, and we can see it becoming a reality and really working as it should, which is already good, that the plan is good, but now we need to make it real, because for now it's just a regulation or a plan. And I think the Netherlands is one step ahead in this sense, and we should also take lessons from their experience to the other countries, and maybe AI SimForMed and other projects can also inspire a little bit the making this regulation a reality, because having this common framework, a lot of barriers will be overcome, and we will be able also to give more power and voice to the individual citizens in the ability to share or not their data.
Thank you. Chantal and Maria.
Yeah, I think that it's also going to be very important how the European health data space is a tremendous chance to get this organized well. And I think the Health Data Access Body is going to be a very important part in that, to get the infrastructure and the set of agreements and the communication information towards the patients done correctly on a national scale. And the next challenge I see is the stakeholder engagement and the co-designing of the different health data access bodies within all the European countries. So, yeah.
Okay, Maria, we are not forgetting.
Yes, exactly. The keywords are in the title. So the words real world, when patients are living in the real world day to day. And this I think expresses a promise that research will be better aligned with this real world of patients and their unique journeys.
Thank you. Thank you so much. A round of applause to this incredible panel. We are now going to a break, 30 minutes. Thank you so much, dear guests, Zoom participants. We are going to break now for 30 minutes.